it's great to be able to have a chance to talk to a group of professionals who are doing very close work in the body and similar digital innovation. And I'd like to pay my respects to the land where I am at the moment, of the elders past and present of the Yaru people and their leaders emerging as well. I've been living in Broome for 2 years, and it's after 10 years of visiting here, and it's a great privilege to be able to live in the Kimberley. And what I wanted to chat to you today about was how we've been on an eye health journey, and hopefully there's some similarities, and you'll nod and say that sounds the same, but there might be some things that are outside the box and you can consider in the ear space as well. And so I thought I would start with a little snapshot of a road that was history from last year. It's now bitumenized all the way up the Dampier Peninsula, just north of Broome. And I'll show you a snapshot here of the locations where we run eye clinics through Lions Outback Vision. So Lions Outback Vision started 10 years ago to try to coordinate the eye care between the optometrists who are visiting some of the smallest communities and the ophthalmologists in the hospitals doing surgery. And it's really great when optometry visits can occur in the Aboriginal controlled health organisations, and with a slit lamp and a retinal camera, these services have been spread throughout the state. And then there needs to be a pathway to refer the patient and have some surgery if required. A little bit of research a while back showed that we really are in trouble when it comes to providing adequate access to the regions in West Australia for ophthalmology. We needed, if you look at those blue circles along the bottom, we needed 11 ophthalmologists to arrive to help service the population of Western Australia to match that of the cities around Australia. And that's just not going to happen overnight, particularly, but it would cost a lot also to try and fly in and fly out to the same level as the cities. So we had to think outside the box, of course. And when 2011, the government said we could do video conferencing and telehealth, thought this was fantastic, a way to be able to connect to the regions. But the first 100 or so cases that we did and audited, turned out there were only 3 GPs that had actually referred, and 2 of them was my brother and my dad down in Albany. But 97 of the cases were actually optometrists. So optometrists really took it up, even though it wasn't a Medicare initiative to involve them. So I'll just show you this slide here, which is really the blue loop is the optometry, the orange is ophthalmology, and the general health services are a key link as well with the general practitioners and the Aboriginal health workers. And in the middle of this diagram, we have the diabetic retinal screening, which is traditional telehealth for eyes. That is store and forward, take a photo, send it away, get a report back for whether they have diabetic retinopathy or not. But the concept of speaking on a video and chatting about other eye health conditions was new. And that's what I'd like to explore a bit today. So this is a lady from Jigalong, Mavis, and she was able to, through the optometrist in Jigalong, have a discussion with her daughter about how her cataracts needed surgery and what that involved. So that meant when she came up to Headland, the first time I met her physically was actually ready for surgery. And we can do measurements on the day of the surgery to get the operation calculated for their vision. And Kerry Woods there has been an Aboriginal health worker with us for many years and has been instrumental in helping patients navigate the health system. And we can do the surgery, get the cataract out, and the patient, daughter and granddaughter can all fly back. And the key point here is that the surgical wait lists are all long, in most specialties. So at the moment for ophthalmology, it's about 1 year for getting your surgery done. And to add an extra waiting time for the first outpatient assessment was really crazy. It still happens around the country and in many areas, even in the cities. You get a referral for someone who's known to have cataract, might be blind from it, and it might take a year to get your outpatient appointment, which is not recorded as a waiting list really until they're now put on the wait list. So the telehealth just bypasses that first hidden wait list, the waiting time to get seen in outpatients, and then can also deal with the post-op visits as well. One of the problems we had was getting the right equipment for a lot of the follow-up face-to-face, and this vision van was a project 5 years ago, which has 3 specialist rooms and all the lasers that we need. This vision van is in Roebourne today, still going around the state providing a service to enable the follow-up, because if you have a telehealth system, for us it was key that we could actually provide face-to-face, and it's turned out that about 20% of people need a face-to-face clinic, 1 in 5, to actually figure out more than the telehealth can offer. This is the route of the van, although it's changing a little bit because now we have a new centre in Broome, and I'll talk about that a bit later. And these are patients from the NG lands who were able to visit Kalgoorlie directly for surgery. So I thought I would discuss some of the published audits and work that we've done about telehealth. And it's really summarised in one slide so that I don't bore you with too many graphs and other information. But the waiting times for our surgery from time of referral have been halved thanks to telehealth. The ability to do on-call telehealth had a 10-fold increase in access for Aboriginal people. So we had a booking system where you get seen by the optometrist, worked up with images and booked in for another day. But that was not suiting a visit to a remote community that was only there for 1 or 2 days. And the logistics involved in bringing the patient back were an issue. So the introduction of an on-call service was key. We've done cost-effective studies to show that it makes a difference and it's cheaper to run. We've done patient satisfaction surveys with 96% of patients happy or very happy, and the remainder equivocal. This was done in the early days, and I'm sure some of you are aware that the technical issues of connecting to a patient can be a bit of a burden at first with new, unfamiliar with videos. However, that's become really a part of life for most people since the pandemic. A systematic review also showed that the outcomes of the telehealth for eyes were equal or better. And of course, as mentioned, it eliminates these pre and post-op visits. So multiple visits are avoided through the telehealth. So what are the barriers that we found for the teleophthalmology? It's actually really the availability of people. So you have to get 2 clinicians to be on time together. And the rhythm of an optometrist and an ophthalmologist turned out to be quite different. I think if you visited an optometrist, you're generally on time. You have a half an hour appointment and there's very nice customer service. But if you visit a specialist in a public setting, it can sometimes be hours of waiting and not so much time with the specialist, etc. So telehealth actually had to become our priority in the day. Kind of had to drop everything to enable the specialist link for that patient to occur, because you're keeping a GP or an optometrist waiting, you're keeping a patient waiting. And so that took a while to be able to figure out a way to get our rhythms the same. The other issue had been the sort of paperwork in apostrophes, because keeping the digital records correct and mapping out referral pathways was an issue initially, and we had to overcome some barriers there. But it really wasn't technology and it wasn't cost. because the equipment is sitting in hospitals, dormant, while we're not there for eyes, and the equipment is sitting in the optometry rooms around the state already. Then you might ask about the video conference facility itself. Well, especially now, that's everywhere. But in 2011, Australia was quite forward-thinking in that any video consultation platform was deemed okay. There weren't the same HIPAA requirements that were placed in America, for example. And so Skype and other very ubiquitous technology was available. And this actually meant that for optometry, I didn't have to try and convince anyone to purchase extra infrastructure all around the state. They just had their normal computers and tablets and smart devices, and it worked really well. So look, you might ask, why bother with the video conferencing bit? Because around the world, some telehealth systems, there's no talking to patients. It's all about images, reports. It's a bit like sending off for a blood test and your photos are graded and that's it. But the way Australia encouraged the video chat actually made a big difference, because if you're going to consent someone to surgery and the first time we'll meet that patient is actually on the table or just before surgery, it really has helped to have some familiarity with the person who's going to operate. And also a formal consent can be carried out effectively. The risks and benefits can be discussed as per usual, choices of focus and lenses that we have to talk about after surgery. And the patient rapport can be established. In effect, we can actually have a better feel for whether that patient's going to cope with local anaesthetic, with requiring a general anaesthetic, level of communication that we'll need during surgery. So it's a really helpful process having had the video discussions. It also makes the patient really involved. They are sitting there with two clinicians, the referrer and the referred person discussing, and the medical student sitting there can actually witness something which is quite a fantastic learning opportunity. It's the primary care interacting with secondary or tertiary care, all in the one case study. So the service has been available as a booked service, as I mentioned, since 2011, and on call since 2015. It's also been enabled to be sustainably funded through Medicare, and that's something that we had to advocate for. In 2015, Medicare changed to allow optometrists to also be able to do video consultations and bill. And that was really important. It didn't take much convincing because the case was so clear, and the research base was there. And the optometry and ophthalmology colleges both said, makes sense, let's do it. And so Medicare was amazingly responsive to that. So a little snapshot of what's going on since COVID. There were 8 rural towns that actually have an optometrist in the town, and the emergency departments, the GPs often refer eye cases to them. So anything that's a bit tricky on the eyes gets sent to these primary care providers. And these towns don't have a specialist, so it's a no-brainer to do good telehealth there. But we tried something new, which was a lot of patients had referrals sitting in the hospital system in wax, and our equipment was in cupboards. So the regional optometrist was able to go into that clinic in the hospital and see patients with our specialist equipment. And this was particularly relevant with intra-regional border closures, when it was not possible to get, from Broome to Headland was not allowed at that time. The other idea was that we have some letters that arrive with all the images, all the requirements for making a clinical decision, and the patient is not in Headland. They've driven back to Marble Bar or somewhere. So all it took was a phone call on a landline, nice and clear, especially for our patients that, unlike yours, it's a different story. They can actually hear better than they can see. So the video is not so relevant if someone's fairly blind from their condition, but they can actually hear better on their traditional landline. And because of COVID, the government basically said, just sort out telehealth as you can. Here's some much greater freedoms on how it's run. And we were able to start doing telephone calls, which patients couldn't believe. They pick up a phone and talk through their condition history. And like many parts of medicine, the history is so crucial to work out what's next. So we did it at home. So the audit of that shows here where not only was there more telehealth during a short border closure, we only had a very short one in West Australia, fortunately. So it was really just in 2 months of that intra-regional border closure, we saw less face-to-face in the optometry store, which is the blue bar, but we had a range of people who were assessed in the hospital, which is the red-orange bar, and then the yellow was telephone calls, and that was a whole new thing for us and really practical and simple. Now, I won't really go through all these boxes, but the top line says, was the patient discharged from care? So telehealth was good enough to say you can go home and not come back again and we've got a plan. Or do we need to see you face-to-face for a follow-up to check on treatment or work out what's going on? Or can surgery be directly booked straight to operating theatre waitlist? Or is another telehealth appointment suitable to be conducted in the future? So if you drop down to the bottom line, those kind of averages are fairly standard across them all. There are not many differences. So 28% can go home or stay home and not have to be seen again. And 1/4 of the patients can actually be booked for a surgical procedure. And that's thanks to the quality of the referral. That is much higher rate of surgery booking than any city clinic. There's nowhere really that gets 1 out of 4 patients requiring surgery. And it just goes to show that the optometry triage process has enabled a really good distillation of pathology so that we're sharing the care and we're working collaboratively and not duplicating our services. So this is one of the optometrists and chatting from a temporary Broome office that we had. So I'm just going to jump through to some other little part of telehealth to wrap up. And I know lunch is waiting and it's been a morning of learning, so I won't keep you too long. But I thought I'd talk about retinal screening, which is the concept of checking for diabetes in the eye and picking it up from a photograph. And we have cameras right throughout the state in Aboriginal health services and GP practices. And the reason for that is you can prevent disease. You can spot it early, screen, and prevent blindness. But for some reason, this is much harder for us to get to increase uptake. And it's not availability because you don't need to hook in with the video. So there's no rhythm problem. But it just seems that it's a constant challenge to be able to train people to be comfortable with the camera, even though some of them are quite easy. You can be taught something and next month when you come back, something's not quite right. The cords don't meet up or the USB stick's not working. So we haven't got that seamless. And there's a delayed feedback loop. Patient has a photo done, no idea whether it's good or bad. Often about 1 in 5, unfortunately, you can't even tell what to say. You have to get that patient back anyway. And everyone's just too busy. I mean, when you think about the priorities of healthcare, you can see perfectly well why waste time checking on an eye camera when there's a lot of other people waiting in their wait room with more pressing issues. So it's never been easy, but it's meant that we've really been interested in artificial intelligence and how can this help us in the future with 2 things. Number 1 would be, is the photo gradable or ungradable? If it's not gradable, we need to dilate that patient and that drop needs to be put in. It will save that patient coming back on another day. And the second thing is the patient will have a traffic light system that says this one is needing to be referred, and let's talk to the specialist right now on telehealth to discuss why and what's next. And the rest of the patients, 70% or more, can say, your eye is looking good, we'll see you in 1 year. And that would make a big difference, having an on-the-spot plan and then the telehealth live for the ones that really need it. So there's an instant feedback there. So in the lab, in perfect world with lots of great photographs, the AI technology, the algorithms beat the specialists. They're better than the human graders. But in the real world, it's been a real challenge. One, you have to sort of validate it for every different type of camera. The AI algorithms need to figure out which camera you're on. They also really need to validate for every population. Our Aboriginal population has different shaped eyes. So if you had an algorithm to pick up glaucoma, for example, it would say half of the population has glaucoma when they don't. And as you all know, with normative database on these cameras where they have green, orange, and red, they're based on very small populations of about 100 or 200 people. And they're not that effective in all populations. So AI needs thousands of photos to really learn properly. And then it has to be approved by the FDA, TGA, to be clinically sufficient to actually provide that level of diagnostic accuracy. So there's some exciting projects that we've been involved in because we have a huge retrospective database of retinal photography for Aboriginal people. And so through WAHEC, quite a few years ago, we've had ethics approval to work with a number of research groups. We've been working with Google for a couple of years as a research project, essentially about to be published. And it's very interesting research. It's been accepted in ophthalmology journal. It's called Ophthalmology. And it shows that the thing called an OCT, which is a camera that shows thickness and swelling, 3 dimensions, is essential for whether we have to do an injection for the eye for diabetes, for maculopathy. But the 2-dimensional photograph that most clinics have can't actually tell whether it's swollen or thickened. So we taught the algorithm with side-by-side photos of a 2-dimensional with 3-dimensional ground truth, and the algorithm learnt to see in the 2D photo whether there's swelling or not. So that saves a machine costing 20 grand versus $70,000. And the machines are already in the clinics. So it's a great advance to be able to use those AI techniques. We've also been working with Centre for Eye Research Australia in Melbourne, and a project has been undertaken and published in Derbyl Yerrigan with the population there to include and validate the algorithms, and they were very successful. So now we just need to integrate them in the camera. So there's literally the camera takes a photo, traffic light comes on and tells the Aboriginal health worker or the GP or the nurse, this is the answer, and we can communicate that with the patient. At the moment, we still have to drag and drop, transfer to a computer, do a few wiggles, and eventually you get your report. But we just want to make it seamless, and that's the next step underway in development at the moment. So these are the new cameras that have been put in primary clinics, the first place in the world to have these machines, 5 of them set up in primary care settings to work out what can we really achieve with OCT, the 3-dimensional photography, and also a new thing called OCT angiography, where you don't have to put the dye in the arm. You can actually see it without dye, non-invasive, and that's a breakthrough for learning what to do with diabetic maculopathy. There's great software now, and I'm sure it's available in your field as well, but this enables us to have live feed of the entire scan. So there's 156 scans or B-scan images, and you scroll through to see all the layers. It's a bit like a radiographer, a radiologist, and we can now do that live from the various remote sites, which has made a big difference, enabled rather than a screenshot summary. You can see the fine detail. And just to wrap up and see if there's any questions, what we're doing right now in Broome is a really exciting project, and I hope to work more closely with EAR health people, because at the bottom picture you can see a sort of double-story structure that's built at the moment. It's a backpackers in Broome, right next to the airport, that's turned into an eye clinic and accommodation. And the building on the other side, the single story, is currently not there. It's just been demolished and had to be rebuilt. So we have till July next year to look forward to a multidisciplinary clinic, cafe, optometry store, research facility, and some places where allied health diabetic educators can set up shop, and our patients can really have quite a comprehensive checkup when they come to see the eye doctor. So this is where we do all our telehealth from now, because we have a publicly funded department of ophthalmology, if you like. There's only 2 of us at the moment, but we're working on having 3 ophthalmologists to cover the Pilbara and the Kimberley from Broome, with the little visits every month to the locations to do surgery. So next week I'm in Headland and Karratha, for example, but we fly from Broome. And the same this week, we were in Kununurra and Halls Creek. So we're looking for a 3rd ophthalmologist for middle of next year. So thanks so much for listening to this talk, which is a bit of a different take, and I'd be very happy for some questions to take it further.
Thank you, Angus. Were there any questions from anyone?
Hi, Angus. I'm Joanna. I'm a GP in Kalgoorlie, but I also go out to the NG lands. My question is about consent over telehealth. How do you do that practically? Is it valid to consent somebody verbally over telehealth?
It is, yes. So we write on the MR20, you'll be familiar with, that it was verbally consented via telehealth. We also attach a 1-page summary report for every patient we see in telehealth, which has the clinical findings that are sent with the MR20. And the patient is having a conversation with us. So in actual fact, we are having the same conversation we would have if they were in the clinic. And then on the day, we can't assign the form. So the patient puts a signature and the specialist puts a signature physically on the day of surgery.
Great, thank you.
Any other questions? All right, well, thank you very much, Angus, for taking the time. Oh, sorry, there is a question. Oh, sorry.
That's right, thank you. Hi, Angus, it's Intan from UWA. Be interested to hear about the scalability of that AI platform that you're planning to implement in WA. Is it something that can be, I guess, replicated in other sort of Australia-wide and globally in terms of, learning the AI algorithm around the images from that particular region for that particular population, that framework, and then replicate it into the algorithm?
Yes, well, good question. And that's exactly why we are doing this research, is not only to be helping Derbil-Yerrigan patient population, which is important, but the implications are broader. And the main research project on that front is with Google. So a paper that's about to be submitted as well is actually it's an international study across many different populations. Essentially all of these algorithms are being developed to have a much larger global reach. And that's the beauty of the software, is that as long as enough people are involved and the algorithms have been trained, effectively labeled, then it's got that broad reach. And the one we use from Melbourne is also validated among global population. The trick then is to get through FDA and TGA, and there are hundreds and hundreds of people working on these algorithms, and they all seem to be very effective. So there's even competitions on Kaggle, which is a sort of subsidiary of Google, and you have 40,000 teams coming up with these projects and winning $20,000 cash. So it's incredible to see the scale of coding knowledge and AI development.
Great, thank you very much. Would you all join me in thanking Angus for his time today? Thank you, Angus.
Thanks so much. All the best.